All right, on page 1030, this is the part 3 of the Chapter 48 series, is the nursing care plan for the patient with a spinal cord injury. So look under the risk of autonomic dysreflexia, which is on page 1031. Of course, we're going to look for those signs, and it tells you exactly what the signs are. Sudden high blood pressure, bradycardia, headache, pale skin below the injury, and goose flesh. I think you all know what goose flesh is, but it looks like goose bumps, basically. Or chill bumps is another way that you might look at that. If you suspect autonomic dysreflexia, immediately take the patient's blood pressure and continue to monitor it every 5 minutes. So we're looking at it every 5 minutes. We're making sure that we've gotten it under control. We want to prevent complications. You also want to place your patient in a high Fowler's position. That high Fowler's position uses the same effect of orthostasis to control that blood pressure. Allowing that blood to pool in the periphery can help reduce that blood pressure. So that's why we want them in that high Fowler's position. Evaluate the indwelling catheter for patency. If it's not patent, it's not in place, the bladder is going to be full. We need to get another order to replace or insert a catheter immediately. And then, of course, monitor that blood pressure while we're catheterizing that patient. Also, we want to perform a rectal exam to determine whether an impaction is present. If you have an impacted rectal area or bowel, we want to make sure we put an anesthetic ointment to the rectum before we disimpact this patient. Because that will help reduce that rectal stimulation, which could make the symptoms or the exacerbator symptoms. Also, while you're disimpacting this patient, you're also going to have another nurse checking their blood pressure. You're going to stop disimpaction if that blood pressure increases. There is a lot of information in the nursing care plan. I would go and read through the interventions for each of the nursing diagnoses. You can read the rationale that may help you as well. A lot of it is things that we have already covered. So I'm going to kind of skip over all of that and skip over to page 1037. If you look at table 48.8, it gives you a spinal cord injury summary. I definitely would look over those because I think that will help break down the information a little bit easier for you. Then I'm going to go down to neurodegenerative and neurocognitive disorders. Make sure that you know what neurodegenerative and neurocognitive means. Okay, I'm going to talk a little bit here about, and if you kind of think about it and break the word down, neurodegenerative. Degenerative means basically wasting. Neuro would be your neurons of the nervous system. So neurodegenerative is just a term that we use when it means wasting basically of the neurons. Okay. Neurocognitive is the term we use to describe acquired neurological disorders that cause cognitive decline. Management of chronic conditions does not focus on short-term stay in the hospital as a result of an exacerbation of the disease process, but rather on the long-term goal of helping this patient and family to cope with the disease process and maintain the patient's independence as long as possible. So, really with this, we want to we're not focusing on the short-term part of that, we're focusing on the long-term goal. We want to make sure that this patient is going to be as independent for as long as possible. And one of the things that we might really suggest to this family is that they attend a support group. Because this nursing care is going to involve a lot of work. It's going to be a lot of preventing and treatment of complications. And so as this patient begins to get worse over the time frame, that family member is going to get eventually to where they can't care for this patient. And so they're going to have a long-term care facility to take care of those needs. But like I said, we really want that family to attend support groups. We may have to get referrals to those support groups, but we want to encourage that. Dementia is under this title of the neurodegenerative is actually a neurocognitive disorder. And dementia is a disease. It's not a disease. It's rather a symptom of a bunch of neurocognitive disorders. And the cause of dementia can be Parkinson's, Huntington's, Alzheimer's, and we're going to talk about that in a little while. It can be from strokes, alcoholism, a bunch of different things. And I know in all your clinical settings that you have seen lots of patients that have had dementia. Dementia also can be caused by some medications that the patients are taking. And so make sure you kind of read over dementia and you know a little bit about dementia. You're going to see a lot more about dementia in the future as well. Delirium is also another disorder that we see, and it's really just a mental disturbance that's temporary. You may see that with dementia. You also can see delirium is considered a medical emergency. We should try to diagnose it and treat it properly. And delirium is basically just disorganized thinking, difficulty staying focused. If you've got a patient, we often tell you that's confused. A lot of times we say, especially an older person, look for UTI. Same thing with delirium. If you start seeing a patient come in with delirium, a lot of times we need to kind of figure out, what's an underlying cause of that. On page 1042, it talks about, you got a little nursing care tip. Make sure you read through that. That's got some good information in it. And then look at Parkinson's disease. Parkinson's disease is a chronic degenerative movement disorder that arises in the basal ganglia of the cerebrum. Parkinson's disease is typically thought of as being a disease in the older adult. However, we're seeing it in people that are younger. An example your book gave you was Michael J. Fox. He was diagnosed at 30. So we are seeing it some in some younger people as well. Pathophysiology. Parkinson's disease is caused by destruction of the cells of the substantia nigra, resulting in decreased dopamine production. So with Parkinson's disease, their dopamine function and production is not what it should be. And so therefore they get in, their neurotransmitters in their brain are not getting the dopamine that they need. And it's what causes a relative excess of acetylcholine. And then it results in tremors, muscle rigidity, and akinesia, which is loss of muscle movement. We don't really know what causes Parkinson's disease, why some people get it, some people don't. But we do know the signs and symptoms are usually gradual and subtle. Typically, this patient's going to have a shuffling gait, which is difficulty initiating movement. And it can be apparent when the patient tries to start walking, rise from a sitting position, or even begin dressing. And the shuffling gait is a cause for a big safety fall risk. So, like I said, shuffling gait is a cause for a big safety thing, and it's because of the fall risk that these patients have, because they're shuffling their feet, and their feet can catch on the floor or rugs or wherever, and they can trip and fall. And those falls injuries can be ranging from bruises to fractures to the head or spinal cord injuries. So, we also see that constipation is a common problem because of decreased activity. They're not able to take in like the food and the fluids. It could be a side effect of their medications. So we encourage them to increase their fiber and fluids in their actual diets. Some medications that we use are on page 1045 in table 48.1. Make sure that you know what the dopamine antagonists are and what the dopamine antagonists are. The Mirapex is the common one that we're seeing a lot. Requep is another one that we're seeing a lot. And there's can cause, so things we want to make sure we're looking at is that these medications can cause nausea. So we want to make sure that we give them these medications with meals. We want to caution our patient about drowsiness and sleep attacks. And basically sleep attacks are just sudden bouts of excessive sleepiness. And so we want to tell these patients not to drive until the effects of this drug is you've taken and that you're fully know how they affect you. So we really want to make sure that we're paying attention to that. And then like levodopa is a common one that we use as well. And so we want to, like I said, give these with meals again, just to prevent that gastric irritation as well. Alright, then we flip over to Huntington's disease on page 1046. Huntington's disease is progressive, hereditary, degenerative, incurable neurologic disorder. Huntington's disease is also known as Huntington chorea, and it's inherited from an autosomal dominant manner, which means each offspring of the affected parent has a 50% chance of inheriting the disorder. And so with this, a lot of times what happens is, and I actually had a home care patient that I took care of for a long time. I actually had him and his sister. Their father had Huntington's disease, and then every one of the children ended up with Huntington's disease. All but one child, he did not have it. They usually start having symptoms about middle age, and it develops slowly and then just progressively gets worse. Cognitive signs can be noticed before you start noticing the movement problems. And what's so bad about it is with the patients, they start getting personality changes. They may be like irritable, they may have like mood changes. Some of these are paranoid, like got a lot of paranoia. And then the physical symptoms develop slowly. They eventually start getting irregular, involuntary, jerky, dance-like type movements. The patients that I actually cared for in home care, the father had it. He had already passed on, but all the children had it, and the oldest sibling actually was one of my patients. He was bedbound by that point that I got him as a home care patient. But really didn't show very much emotions, period, at all. He would just kind of lay there and look at you. Didn't say a whole lot, but he had like real fine, jerky movements. I mean, and he would just be jerking. Sometimes you even wondered if he had seizures, but it wasn't. And then his sister has it, but hers was not as progressed as his was. And now she pretty much just has a lot of jerky movements, and you know how you would almost think she kind of acted strange sometimes, but a lot of it was the mood disorders that came from the Huntington's disease. And then her youngest brother has now started showing signs, and he has the jerky movements, and he just sometimes can be irritable. Biggest thing with these patients is we want to make sure we have genetic testing, especially whenever we already know that an individual in the family has it. We want to do genetic testing like prenatal wise, and then after the patient's even born or progressed on into age, we can actually check them to see if they have the Huntington's disease before they ever become symptomatic. And like I said, a lot of times we don't see this until the people are in their 30s and their 40s. And by that point, they've already had children and they're affected by it. There's no cure from Huntington's disease, so we really just try to minimize the symptoms and prevent complications. Nursing care-wise, of course, we a lot of times care for these patients on an outpatient basis. We just try to treat their symptoms. There's a good picture on the top page of 1048. There you can kind of see kind of what a patient may look like and some of their movements. Then we have Alzheimer's disease. I know all of you have taken care of a patient with Alzheimer's disease. That's the most common type of dementia. It is a progressive loss of mental functioning that interferes with the memory, ability to think and clearly learn, and eventually the ability to function. There's different stages of Alzheimer's disease. There's stage 1, that usually is the very early stage. It's where they just have increasing forgetfulness from about 1 to 2 to 4 years. Stage 2 is the longest in duration, lasting 2 to 12 years. Progressive cognition deterioration causes difficulty during simple calculations and answering questions. Depression is very common. They start having an abnormal sleep-wake cycle. They tend to wander aimlessly, particularly at night. And then you have stage 3. Stage 3 is characterized by the progression of complete dependence. So they lose their bowel and bladder control. They become mobile. Or they still can be mobile. They just need constant supervision. In stage 1, some of the nursing care things that we can do to help this patient is just make lists to remind them of their tasks that they need to do. Stage 2, make sure that all doors are locked. So nursing care again, stage 1, make lists to remind the patient of their task because they're beginning where they're forgetting those tasks. Stage 2, you want to make sure all doors are locked where potential exit exists. Just make sure that, if they're up wandering at night, that they don't wander out and get injured. So just make sure that they're locked so that they can't get out. And then stage 3 is the loss of their ability altogether. So therefore, we sometimes have to go to complete total care. Okay, as far as the differences in Parkinson's, Huntington's, and Alzheimer's, if you look on page 1050, table 48.12, there is the different symptoms, and it'll tell you if it's in Parkinson's, Huntington's, or Alzheimer's. That might be a little table that would be very helpful in knowing the different symptoms of the different diseases. Definitely look over the green box for home health hints. That's always good little hints for nursing care, as well as to what to teach our patients. That's always good nursing care. And that concludes Chapter 48, Nursing Care of Patients with Central Nervous System Disorders. I will be posting on Canvas a study guide for Chapter 48. Make sure that you complete that and submit it just like you did for Chapter 47.